Hi, my name's Paul Grimm. I'm a pediatric nephrologist and fellowship director for the Stanford Pediatric Nephrology Fellowship. So, as you know, this recruitment season is all virtual, and we're trying to give you a flavor of what this place is like. And if you decided to match to our program, and if we were lucky to have you, what your life would be like for the next 3 years. Um, Our program has been around for 30 years. We have a lot of graduates who are in various different walks of life. We have some people who have never practiced after finishing their fellowship because they're in business, designing new technology and equipment, or in the FDA, or many other people are in practice in various academic settings throughout the world and in clinical settings. So in a lot of places you go, there's a connection to Stanford. Our goal is for you to be the best pediatric nephrologist that you can be, and also for you to increase the fame and the status of Stanford. So we want you to be outstanding. We want you to be a leader in the field. We train people who can do research, who can do advocacy, who can do excellent clinical care, but also we really want you to have fun while you're doing it, because as you'll get to know, our faculty really enjoy the job and really enjoy being pediatric nephrologists. Sure, we all have our down days, and sometimes things don't go the way you want it, but in general, we have fun. And we also really respect and like each other. So often I do a fully face-to-face discussion with people, but that doesn't really translate well to a video format. So I do have some slides. So let's see about sharing my screen so we can start talking a bit more. Here we go. Yeah. So this is some of our people. This is held at our party that we have in the summertime at my place, which is actually on the campus. And obviously we don't have these now in COVID time, but we're hoping to be able to get back to it. And so I'm just going to point out some of the people here. So this is Dr. Ha Tran. She's a pediatric nephrologist, graduate from our program. Her parents came over from Vietnam after the war, and so they were basically boat people, and they built up a life. And she does amazing things. She right now is a medical director for Baxter, which is one of the world-leading dialysis companies. So she is part-time with us and part-time with Baxter. So we have an in for some of these new cool technology interventions, and someone who's really pediatric, who's an advocate for developing new technology. At the other end of the spectrum, this is Don Potter. Don had a full career as a pediatric nephrologist at UCSF. Then he retired, and less than a year later, he and his wife and our division head, Steve here, were at a party. And she basically leaned over to Steve and says, "Steve, you have to find my husband a job because he's driving me crazy." So anyway, we brought him on as a part-time to be the Fellows Clinic supervisor. And he says this is the best job he's ever had. He's the happiest he's ever been because he gets paid for what he knows. So he basically runs the Fellows clinics. He sits there, the Fellows present patients, he argues with them, he discusses, he pushes them, because like in his bag, he can pull out a paper from the 60s, or he'll have a paper which is in preprint, it hasn't even been published yet. And he'll talk about the papers and compare them and contrast them and say, see what the understanding of the physiology or the pathophysiology has changed. And this is why. Or he'll say, what the hell are you doing that test for? The fellows call him Dr. Potty-Mouth. They love him to death. And he brings tremendous experience. This one here, Vaka, she just graduated from fellowship, and she went back to Iceland where she's doing a PhD. And once her visa issues are sorted out, she'll probably be coming back to the USA. This is Ken Sutha. Ken's got a real presence on social media and an advocacy for organ transplantation and advocacy for minorities, and he's very prominent at Stanford. So if you've been searching or exploring Stanford, you've probably seen him on one of the many different websites or videos about him and his life. He is doing cool research on growing kidneys in the lab, and I guess he's been with us on faculty for 2 years. Sarah here, she's one of our fellows. She's really interesting. She's passionate about global health. And so her academic project is to improve the identification and management of hypertension in kids in Ethiopia, because there's no dialysis for them. So you can sustain or improve their lives by getting them early enough to improve blood pressure control, which is a real problem. So she's really got an interesting story. Steve is our division head. And he's going to be around for a long time, we hope, because he does an awesome job. He's from Texas, and you know that because he has a different pair of cowboy boots for each day of the week. And he told me why one day, that he wears a different pair each day, more than I needed to know. He is one of the leaders and one of the innovators in pediatric dialysis. If you read the classic pediatric dialysis textbook, that comes out every few years, updated. He's one of the editors, along with Brad Warday. Abanti Chowdhury. Abanti is a jack of all trades. She also trained here. She runs our hypertension clinic, our Williams syndrome clinic. She's the co-medical director for the kidney transplant clinic. She does a lot of outreach clinics in addition to raising her kids and getting only like 3 hours of sleep a night. Elizabeth Talley. Elizabeth is the associate program director for the fellowship. So she has meetings with the fellows that focus especially on quality of life and wellness and figuring out where you fit in the world. She is a tremendous advocate for diversity. She's a leader in our department diversity initiative. She comes from a multi-generational family from the Bay Area here. Lakshmi here. Lakshmi just graduated from our fellowship program. She was a trailblazer because she was our first Med Peds fellow. So she did a year of clinical work in the adult internal medicine side, and then she did a year of clinical work in the pediatric side, and then 2 years of research total. And during that time, she did some continuity in peds, some continuity in adults, but her passion was the transition clinic, the transition of teenagers to the adult world, and especially in kidney transplant. And she really did some pioneering work, which is going to be published in that area. In the front row here, we have Jill. Jill is one of our current fellows, and Jill is passionate about advocacy. So she brought in a questionnaire that now every nephrology patient is given on coming to clinic, on food scarcity, and she is a JELF scholar. So she is one of the prestigious group of people that are picked. Usually they're junior faculty, but they picked her as a fellow to get extra training from the American Society of Pediatric Nephrology and go to the Hill to advocate with government for pediatric nephrology issues. Sonny over here, Sonny just graduated from our fellowship program, and he now is at Children's Hospital of Orange County. And his passion was big data. So he did his research and academics in clinical epidemiology and analysis of big data and natural language processing to pull out pediatric nephrology issues. This is me. This is Scott Sutherland. Scott is our director of acute therapies for the inpatient hospital. So he manages our acute dialysis, and we also own the plasmapheresis for the hospital. So he supervises that. In addition, he's a department co-chair, I think, for clinical affairs, and he's very active in the AKI at a national level in the NINJA projects. He's written papers in the New England Journal on AKI and the NINJA project, and so he is often one of the highly sought after mentors for academics for the fellows. All right, what are you actually going to do when you're here? So let's start talking about your experience as a pediatric nephrology fellow. And I'm going to go through the rotation diagrams. So this is a rotation diagram for our current year. In your first year as a fellow, you do 14 inpatient weeks, 17 outpatient weeks, 17 research weeks, no electives, and 4 vacation weeks. So when you look at your inpatient week, we do a week at a time. So the outpatient, inpatient research, outpatient, inpatient research. Why only a week at a time? Because it's as much as anyone can stand. The inpatient work is hard and it's long and it's stressful and you have to be on your toes. And although some of the faculty do 2 weeks at a time, most of the faculty do a week at a time. And it's really what is compatible with a good quality of life and really giving the best to our patients. But you only do 14 weeks and you have weeks in between to recover. In second year, you do 3 inpatient weeks. And in third year, you do a measly 1 inpatient week to get it out of the way. It's usually done early on. That doesn't mean you have no clinical work in your third year, because many of the third years realize that pretty soon they're actually going to be the attending and where the buck stops. And so many of the third years will do a pretending couple of weeks where, you know, officially there's an attending that's shadowing them, but they do the work of an attending for a week. So they run the rounds, they take the calls and stuff like that. So you do some pretending time in your third year, but that's totally what you need or what you want. Okay, so 14 weeks first year, 3 weeks second year, 1 week third year, for a total of 14, 15, 16, or 18, around 18 weeks. But you get a lot of training during those 18 weeks. And this is what your inpatient week looks like. Pre-rounding at 7 a.m. and you hand over around 5:30 or 6 to the night call person, Monday through Friday. You're it. You take call the first night, and that's not a bad thing because usually it takes a long day just to get to know the patients. We have anywhere from 12 to 20 patients that you're responsible for at any time on the service. And so you take call that first night. It's not inpatient, it's home call, but it's busy. There's usually a lot of calls, and it's not uncommon to have to come back for a new kidney transplant or a CRRT start or something like that. But then Tuesday night, Wednesday night, Thursday night, you're not on call. You get your sleep, you get to recover, you get to do your notes or whatever you do at night. Friday in the late afternoon, you sign out to the weekend team, but you take call Friday night, wrapping up loose ends and allowing the weekend fellow to start fresh Saturday morning, because they've got 2 full days where they can be crazy on the weekends. So this is your typical inpatient week, of which you do 14 in the first year. Let's look at outpatient. So outpatient weeks are really only done in your first year. And so you alternate between inpatient weeks. Here we have about 17 outpatient weeks. And you don't do official outpatient weeks unless there's a schedule conflict at all in second or third year. Okay? So there you see 17 that first year. What's an outpatient week look like? Well, you carry the pager. This diagram should start at 8:30 a.m., not 7 a.m. But you carry the outpatient pager from 7:30 a.m. Monday until Friday, and then you shut it off at 5:30. So you're not getting a whole lot of calls from patients or parents because those calls primarily go to the general nephrology coordinators or the dialysis coordinators or the transplant coordinators. Your outpatient pager primarily is consults from community doctors, from outside hospitals about possible transfers or for advice. We do a lot of outpatient work, and a lot of pediatricians or ICUs at other centers just need a hand holding or an advice on how to deal with a patient. So you're providing a consultative service and getting a lot of interesting and strange questions. You always have an attending backing you up, and we want to talk either real time or at the end of the day about every call you've gotten, but it's a great learning experience. The first day, Monday, has no clinics, but the other days do. So Tuesday, it's a general nephrology clinic. So this is the attendings clinics. So when you go to the general nephrology clinic, you will drop in on any kind of interesting patient or fun patient or patient that you haven't seen before or something you need experience with of the various attendings that are in clinic that day. On Wednesday, this is our continuity chronic kidney disease or dialysis day. So this is when you see your continuity clinics. So the American Board of Pediatrics recommends a half-day continuity clinic a week. And what we found was to be more efficient and more respectful of your time, we block them. So most fellows do a full day continuity clinic every second week so that they don't have to drive to and from clinic or deal with the follow-up paperwork, and they're free to do their research or something else. When you have chronic kidney disease patients who are progressing to kidney failure, they're seen in our TRAC clinic, which is transplant readiness and anticipatory care. That clinic allows you to have access to the social workers, dietitians, pre-dialysis counseling for the access from the dialysis nurses, and pre-transplant counseling about transplant from the transplant coordinators. And then Thursday is transplant clinic. So transplant clinic is different than in most places. So we're the busiest kidney transplant program in the country for pediatrics. And almost all of our outpatient care is run and managed by advanced practice coordinators, clinicians who are PA or NPs. So they do all transplant all the time, and they really live and breathe this, and they know their patients really well. And they're also very much involved in outreach, because half of our transplant patients are managed primarily by referring nephrology groups, like in Hawaii or Nevada. And so they do a lot of outreach calls and FaceTimes and assisting the local nephrologists and the local patients as well. So they know these patients intimately. So when I come as an attending to transplant clinic and I'm the medical director for the program, I really feel these are their patients and I'm serving as a consultant. So, you know, transplant patients are fun, but after 10th or 15th stable kidney transplant patient, 3 years post-transplant, let's check the meds, okay, see you in 2 months kind of visit, that doesn't have a whole lot of educational value. Well, you don't do those in transplant clinic after you've done a few of those. Every patient you see needs a doctor, because they've been pre-selected by the coordinators to say, okay, this patient's having rejection. This patient is having issues with non-compliance or non-adherence or forgetfulness. This patient's got BK virus. This patient's a fresh transplant and we're juggling all sorts of immunosuppression and antihypertensive drugs. This patient is losing their transplant, and so we have to start them on CKD and start the counseling. This patient is being evaluated or needs a second transplant. So patients that really have a high value and you learn a ton from seeing those patients are the ones you're going to see in the transplant clinic. Friday morning is urgent nephrology. So those are referrals that can't wait for the regular nephrology clinic, seen with an attending, and those are sort of hot off the presses, fresh diseases that require a visit, and that's a fun clinic. And then in the afternoon on Friday, it's our outpatient biopsy. So we do, the medical team does our own kidney biopsies, native and transplant, and we try and batch them to Fridays. Okay, and as the outpatient fellow, you'll do one night call a week. And so I've got the green night call there, say just randomly picked for Tuesday. The first year fellows do almost no weekends of call. The weekend calls are done by second and third years, except covering Christmas and New Year's holidays, and then if the third years are away at conferences. So you do very few weekend coverages as a first year. Education. So education is very important to our division, and this is an example of the curriculum that we have. So Monday, remember there's no clinics Monday. Monday is in the afternoon. That's when we get most of our work meetings out of the way. So there's dialysis from 1 to 2, transplant selection 2 to 3:30, general nephrology when transplant selection is done until shortly after 4. So this is where the teams get together and review problem patients, new referrals. In transplant selection, we refer the patients who are being considered for activation or adding onto the transplant wait list, and problem patients, rejecting patients, donor-specific antibodies, etc. And then at the end of the day, there's CME. So CME is a weekly lecture series specific for pediatric nephrology run by us. So 1 week, it might have a visiting lecturer, or it might be a fellow or an attending doing a topic, or it might be a journal club. And 1 week out of every 4, we do board exam review. So I don't know if you know about this, but the pediatric nephrology board exam is significantly tougher than the general pediatric board exam. And so, you know, we get you started on practice questions and thinking about the exam right off the bat in your first year. So every month we have practice exams for board review. Tuesday morning, bright and early at 7:30. This is core lecture. So these are fundamental lectures about physiology. So, sodium handling, hyponatremia, transplant immunology, dialysis machine physics, uh, hypertension management, uh, and they are given as a joint service by the adult and pediatric nephrology groups together, because hyponatremia management is the same whether you're 2 years old or whether you're 80 years old, right? It's the same physiology. It's the same pumps in the same water channels. And so we get high quality lectures. And this curriculum repeats every year. So it's a standardized curriculum that repeats every year. First years rarely go when they're on inpatient service because they're just too busy, but everybody else goes. So you have 3 times in your 3 years where you can get a specific lecture. Wednesday afternoon, 5 o'clock, renal grand rounds. So this is a renal topic, often done by an adult or pediatric fellow, often done by a faculty member or a visiting guest speaker on renal topics. Friday morning, pediatric grand rounds at 8. This is not well attended by the nephrology service. We go to ones that are important to us, but they don't go to at least maybe half. So this is something that we're working on, trying to get people to go to more of these. But there is no clinic before 9 o'clock, so you are totally free to go to them, but the fellows have a choice, and it's not mandatory. PATH conference at noon on Friday. So this one is always well attended by everybody who's in town. So we do, on average, about 4 or 5 kidney biopsies a week. And we also get outside referral biopsies. And so we get together with a multi-headed scope, and now during COVID times on a Zoom meeting where a pathologist takes us through the biopsies, and then we discuss in a roundtable fashion with the fellows and faculty who are in town how we're going to manage these patients. And then at 3 o'clock is sign-outs, and that's when we're transferring the care of the patients on the inpatient service at the end of the week to the weekend coverage and to next week's inpatient team. And the coordinators from transplant and dialysis go to this as well to talk about outpatient issues. And anybody who's in town usually goes to these, and there's always good snacks, at least in non-COVID times. Now there's Zoom, so the snacks aren't quite as high quality. But that sort of gives you an idea about the standard divisional education. In addition, the department runs something called Common College. So Common College deals with those educational things that are the same whether you're a pediatric nephrology fellow or an ID fellow or a GI fellow or a cardiovascular fellow. So clinical and research ethics, professionalism, work-life balance, statistics, personal finance, curriculum development, if you're going to be an educator, cost effectiveness analysis, all the kind of stuff that is needed to have a well-balanced academic clinician. And that happens once a month during protected time. Research. So as you figured out, your first year is pretty heavy on clinical work. And that's where you really become a great clinician. However, you get 17 research weeks in your first year. And during those research weeks, you figure out a mentor, develop a project, and put together a grant application for internal grant funding competitions. In your second year, you do 41 research weeks. And in your third year, you do 43 research weeks. So over those 3 years, you do about 104, 8, 9, 101 research weeks. So there's the most time you're going to spend is on research. And so we want you to do a great job. Even if you're going to be a general clinician, this is important to become an academic. So you can review the literature, so you can feel like you've got an area where you are a true expert. So when you go into practice, you know what it's like to be continued to be an ongoing learner, to be able to evaluate the research literature throughout the rest of your career. So you can see we really prioritize this because this is where you spend the bulk of your time in your fellowship. So what's it like to be on the inpatient service? So you have anywhere from 12 to 20 patients you're responsible for. When you round, for inpatients that are nephrology patients, like a dialysis patient or acute GN patient or an acute hypertension patient, they're cared for by the red team, which is the resident service. and you have one senior resident and 2 interns. So the senior resident can be a second year, but is usually a third year. About 10 years ago, we switched how we do things, and it's really improved things. So previously, the interns used to only be on the inpatient service, and their view of pediatric nephrology patients was sick, chronically ill, depressing, miserable. Oh my God, they've been in hospital for 3 months. So what we did was we changed it so that the intern does 2 weeks inpatient and then 2 weeks outpatient. And in the outpatient nephrology world, they see these free living kids where kidney is only a small part of their life. A healthy post-transplant patient, someone with hypertension or stones who their big worry is going to the prom or their girlfriend or figuring out where they're going to go to college, or is it okay if I walk dogs with my immunosuppression and stuff like that. And when the interns started doing that, they really got a better balance of what nephrology is all about. And since that time, we've had a fair number of people who were residents at Stanford who went on to want to do a subspecialty in pediatric nephrology. So, and then they don't always dress like this. Yeah, this is the residents when we're telling them there's a new admission, kind of thing. It also might have been perhaps Halloween, but they're really high quality. So my idea of rounding with the red team for a good day of rounds is if I don't say anything other than good morning. I want to be quiet, and I want it so that they don't even recognize the attending is there, sort of like a ninja, just you're there but in the shadows. The intern should run the rounds. They should be talking to the parents. They should be explaining the issues. They should be talking to the team. The senior resident's job is to educate the intern, to keep them within the right parameters, to help them if they're not prioritizing things correctly, to get them to be able to figure out the problems and manage them in an appropriate fashion. The fellow, they provide the content expertise of a nephrologist to the day-to-day rounds. So they're the ones that are supposed to be setting the direction, helping them figure out the game plan, the questions to ask, what are the important questions and the less important questions. So as a faculty member, my idea of a great rounds is for me to not say very much at all, except maybe tweak this or tweak that, or calm down an anxious parent that needs sort of like someone with gray hair to talk to for a while. So that's red team, and those are our inpatients. We share the red team with the rheumatology service. Consultations. So the other half of your job as an inpatient fellow is to manage the consults. So we are the busiest kidney transplant program in the country, the busiest liver transplant program in the country, the third busiest heart transplant program in the country. Our heart failure and heart surgery program is astronomical. Our heart surgeons do simple surgeries at many other hospitals in the area, such as in Valley Children's and stuff like that, and they send the really complex stuff to us. In addition, we do some things that nobody else in the country does, like really complicated unifocalization of multiple aortopulmonary collaterals, MAPCAs. People come from all over the country and other parts of the world for this surgery, which may go on for 24 hours. So you can imagine all this kind of stuff generates lots of AKI, lots of acute kidney injury. So we have a lot of dialysis, and you get to be an expert on dialysis. So here, like in this picture, you can't even see the patient, little kid over here, on ECMO with CRRT and plasmapheresis. We run the plasmapheresis service for the hospital. So if it's someone who has a neurological indication or a rheumatological indication or a kidney indication, we're the ones that know the machine, and we're the ones that do the ordering and figuring out what kind of therapy is necessary. And you become really good at this. After you've been an inpatient fellow for a couple of months, you may get this kind of consultation. Hello, this is the heart failure, heart transplant service. We have a 5-kilo child who's going to the OR in about 2 hours for a heart transplant. She's 100% sensitized to HLA antigens and antibodies, and she's getting a donor, which she's cross-match positive for. So we need you to arrange intraoperative plasmapheresis so we can get rid of those antibodies and get this kid a successful heart transplant. You'll get off the phone and you'll wonder if you need to talk to your renal attending, because this is so normal, this is so routine. You've done this so many times before that you wonder if you even need to talk to your attending. You better just say hi, let us know what's going on. But this is routine. So by the time you're done your first year clinical fellow, you can handle just about anything. We're doing more and more Aqueducts. So this is the latest gadget. This is, when you look at a regular dialysis machine, it's like a good full-size car, like a Tesla or a Honda. But this Aqueduct, it's a Ferrari. It's a tiny device which you can play with and push. And we're doing more and more with the babies on the Aqueduct machine. And it's really a lot of fun to play with. And we're one of the first places in the country to have used it in a research basis, and now we're using it for regular clinical care. Okay, the bulk of the care and the bulk of our patients are outpatient, and this is the workroom of a typical clinic day. Maybe we don't have quite so many snacks as in this situation, but we're known to have lots of good snacks. And you can see people are talking and gathered, and it's a multidisciplinary team approach. Now in COVID times, there's masks, and we are social distancing, and we're looking forward to when this will be gone, when we have a vaccine, so we can get back together to looking after things like this. And you see, it's very comfortable, and people are happy and eating well, and the patients get good care. Kidney transplant. Our kidney transplant program is world famous, and we regularly get pictures like this from people from other states who we've helped and sent back. We do more kidney transplants than any other program in the country, but in addition, our outcomes are better than any other program in the country. So this is from the Scientific Registry of Transplant Recipients. The SRTR keeps track of every single kidney that's transplanted in the USA and puts together these reports. So this is a pediatric report on 3-year graft failure. So any program that has transplanted a child less than age 13 is a dot on this graph. And so this is the program volume over the 3-year period, because this is 3-year follow-up. And this is our dot. So we've done more than any other. We're close to a few other, but more. But the other thing, which is more important, is this is the hazard ratio for graft loss during those 3 years. So they look at your patient population, how sick they are, and normalize them. So the average graft loss is 1. Our risk of graft loss is 41% of the average. So our outcome at 3 years is better than any other program. It's not like we take easy patients. A lot of our patients come from other centers because they're untransplantable at other centers. They have no IVC. They're 100% sensitized, and they've been on dialysis for 3 or 4 years. They need a liver kidney. They need a heart kidney. They have lung disease. And we will take them on. And so in spite of the fact that we take patients literally that have been rejected by other countries, for example, a few years ago, we transplanted a Canadian where no Canadian center would take them. We have this outcome. So clearly we have phenomenal surgeons, but it's more than that. It's because we have wonderful outpatient follow-up. Those coordinators I talked about early on, they're fantastic, and they are sharp, and they identify things early. We do protocol kidney biopsies. We are cutting edge in immunosuppression, and this is a wonderful transplant program. And you will experience that when you're here. But to do a good job with transplants, you need to have a phenomenal dialysis program. Oh, here's a picture of one of our living donors and recipients. They're comparing scars there. Okay. But you need to have a wonderful dialysis program, and our dialysis program is second to none. Steve Alexander, who's one of the innovators and is well known throughout the world in dialysis, turned the program over to Cynthia Wong, who is also a fantastic dialysis doctor and really involved in improving quality. We really push the limit. This is a 1.2 kilo child that we started on dialysis when this child's kidneys were not functioning at birth. You see this giant sized PD catheter, and this is the actual picture of the patient that this x-ray shows with one of the parents' fingers, and you just show what a huge tunnel we had to make to ensure that there was no leaking. And we got this patient dialyzed and transplanted, and this patient is around 3rd grade now, and one of the leaders in their class, normal or advanced intellectually. So this is the stuff we do. One of the things you should look at when you're looking around the country about where you want to be a fellow is, where is their dialysis unit? Unfortunately, a lot of pediatric programs don't have a dialysis unit on site, or it's a block away, or it's in another zip code because it's connected to an adult dialysis unit where they might be sort of an afterthought. Our dialysis unit is in our hospital in the building. So as you walk in the front door of the hospital, you turn right. It's one of the first things you see on the main floor. It's connected to a short stay unit. So you go down this hallway and you turn left and you see the dialysis unit. And look at this place. If you have to spend 3 or 4 days a week, 4 hours a day, you want a place that's bright, that's got windows going to the outside, which this dialysis unit has. We have isolation rooms, but most of the patients prefer to be with other patients so they can talk and tease the nurses and tease each other. There are these separators that drop down from the ceiling. So if you need private time with a patient or the patient needs to focus on schoolwork, that can happen. And we have a teacher that comes and spends time with the dialysis patients when they're on dialysis. So this is a bright, happy unit. Oh, great. Fire alarm. Hang on. Hopefully this fire alarm noise won't affect things and I'll be able to keep going. This is a picture of our PD nurses. So the peritoneal dialysis unit is in the dialysis unit as well. And we have maybe about 40 patients on dialysis on average. And they are on call to help you out at 2 in the morning when a patient calls in with a dialysis problem, and they're wonderful. The dialysis nurses are all cross-trained, and our chronic outpatient nurses also do inpatient acute dialysis. So they know the patients very well. So what this means is we can take a 5-kilo child who needs dialysis 4 days a week and have them as an outpatient and dialyze them in our unit so they can live at home or live in Ronald McDonald House and they don't have to be stuck in hospital. But the dialysis unit is in the hospital. So if something goes south, if a rapid response is needed, or you as the first-year fellow is needed to evaluate them, you're right there. In fact, you are really right there because the first-year fellow's workroom is adjacent to the dialysis unit. So this is the first-year fellow workroom, and there's Hello Kitty and some kind of a Olaf the Snowman in the dialysis workroom. This is a picture taken through the glass window. Again, there's sunlight. We've got a odor diffuser for nice scents. There's lots of snacks, and this is where the first-year fellows hang out and live and do their notes. And so they're just adjacent to the dialysis unit, so you don't have to run across the street or run somewhere if there's a problem where the nurses need some quick advice. Needless to say, there's unlimited coffee in the dialysis unit, so you don't have to worry about that. This is some of our clinics, and I know I've missed some, but I just wanted to point out how many there are. Most of these are on site. So I mentioned the TRAC clinic, transplant readiness and anticipatory care. Patients didn't like chronic kidney disease or CKD. They wanted a positive name, so that's what we called it. And this is great because we have dialysis nurses, transplant nurses coming to these clinics to provide counseling and to help people plan a smooth transition from CKD to end-stage therapy. We have a specialist hypertension clinic. Between our transplant and our hypertension clinic, we must have about 20 ambulatory blood pressure monitors. That we have a very busy service in ABPM, and that's really useful in managing the patients with hypertension. Williams syndrome is a separate clinic. Cardiorenal, for all those kids who've had multiple heart surgeries or a heart transplant, whose kidneys are compromised. Hepatorenal, same thing with primary liver disease. We've got a tuberous sclerosis clinic. We have a clinic where we do prenatal diagnosis and management as a multidisciplinary team for these moms that are carrying a child who's been identified to have kidney disease. Our clinics, our outpatient clinics in Sunnyvale are right adjacent to the rheumatology and urology clinics. So for people that have lupus or people that have chronic obstructive kidney disease or CACUT or prune belly, they can see rheumatology and nephrology side by side in the same waiting room, and then we can talk to each other to make multidisciplinary plans. We have outreach at California Pacific Medical Center, Emeryville, Walnut Creek, amongst others. These outreach clinics, the fellows don't go to unless they want to. Like if they want to see what it's like, they're welcome to go to, but no fellow is assigned to outreach. One of the perks is Hawaii outreach. We collaborate with the nephrologists on the main island at Kapiolani Medical Center, and so we do outreach every 3 months. Of course, we don't during COVID time because of the quarantines, but we will once um, that's over. And we've been doing this for 10 years. And it's wonderful because we get to meet the patients on the island. Many of these patients have never been out of Hawaii and they're terrified of going to the mainland. So we see them on the island, get to know who needs to come to the mainland, who can be managed locally, and get them ready for their transplant so they can come to the mainland, get their transplant, and then go back to Hawaii where they're cared for by a great nephrology team. And here we have, this was one of our fellows a few years ago who did decide to come to outreach. But if you're going to go to Hawaii outreach, you also have to go to Central California outreach. And Central California outreach at Valley Children's means you got to get up at dark 30, way before the sun comes up. And we drive 3 hours to get there by 8 a.m. This is a great picture. So this person right here, you just see the sunglasses, took this selfie. She's one of our transplant coordinators. There's me showing my better side. There's one of our transplant surgeons. And there's one of our social workers who was not impressed about the camera. Uh, but anyway, we get there at 8 or 8:30. We see patients all day with the Valley Children's team, and we come home. And although it kind of sucks, it's a really long day, it is so rewarding. These patients, most of them are farm working families. They have resource problems up the wazoo. Many of them have emergency medical. For many of them, if they have to take a day off to come to the city, they don't get paid that day. And they're living such a difficult existence. Us coming out so they can buzz in quickly to see someone from Stanford about their transplant or their dialysis or something like that is a real benefit, and they are so grateful. So this is a really valuable outreach. We go every 3 months, and again, not mandatory. One of the things I wanted to mention is we're doing our own ultrasounds, and we're developing a pediatric nephrology ultrasound service. And so this is a picture of a patient after a major surgery. That's my hand with one of our wireless ultrasound devices, and that's my iPad. So, in many parts of the country, the radiology program is taking over the kidney biopsies. Interventional radiology is doing them, and the fellows aren't getting much experience with that. And we had a fundamental philosophical question. What were we going to do? Because we wanted to train fellows, and our interventional radiologists are great, and they offered to train fellows. But the reality is, if they're trained by IR, what the fellows are going to be trained to do is watch an interventional radiologist do the biopsy. And we felt that was unacceptable. So we have purchased some wireless ultrasound devices, and all the fellows are being trained up on them. So we have a kit where they take home the device and an iPad, and they can ultrasound themselves or their significant other or their children or the neighborhood children or anyone they can snatch, or their dog for all I care, to really get comfortable with the machine and play with it so you don't have to practice on patients to get stressed out. And so we're deploying these to our clinics. So like, say you have a patient who's 3 years old who has a solitary kidney, and the big question is that kidney continuing to grow? Is there compensatory hypertrophy? Why have the family wait for 3 months worried when you can just slap an ultrasound on them and say, yep, kidney's bigger than last time, growing fine, carry on. We take these to the transplant clinic. So for fresh transplants, creatinine's up today in clinic. Well, let's go take a look. Is it an obstruction with some new hydronephrosis where we need a stent, or is it rejection where there's no hydronephrosis? Rather than moving heaven and earth to get an ultrasound in 3 or 4 hours before deciding what to do, you can do the ultrasound right there, and you can decide, okay, where are we going from here? So this is going to be really revolutionary. I really do believe that in 10 years you may not carry a stethoscope, but I think every nephrologist is going to carry a portable ultrasound device, and so we want you ready for that. We're also doing our own biopsies, so now we don't have radiology involved, so and that's really nice because it provides much more flexibility, and the biopsy takes a much shorter period of time. Anesthesia puts the patient to sleep. You localize with your device. We have some guides we can use if you want. You take the biopsy, recover them, and 4 hours later they can be discharged. So I think this is a really new, cool program that we're bringing on board, and the fellows seem to like it. Okay, changing the subject for the last couple of slides, research. I want to point out we really prioritize your academics. When you graduate, you only spend 3 years as a fellow, but you're hopefully going to have a 30-year career. And so you need to be comfortable with lifelong learning. You need to be comfortable with evaluating the research. If you want to be in an academic center, you need to be able to do research and feel like you're an expert in some area. And so we really prioritize that. And so out of the 3 years, literally 2/3 of that time is research weeks. Now, education is important. You don't just learn research by hanging around in a lab. And the Department of Fellowship Leadership really has a very extensive curriculum for that. And that's covered by many of the handouts on the website and the links. There's an intensive clinical research boot camp, so research immersion week in the first couple months of your fellowship. There's a grant writing boot camp, which is a week. There's grant writing mentorship, where when you're doing your grants, you have mentors outside of the Division of Nephrology who review them, criticize them, and have you redo them. And then there's mock grant review sessions where a formal grant review panel will evaluate your grant while you're in the room, like a fly on the wall, listening to see how they talk about it and how they think about it. All this means that your grants have a much better chance of success. And many of our fellows have gotten national funding, such as from ASN or AST in recent years. Project finding. One of the biggest problems at Stanford is deciding what project you want to do and who you want for your mentor, because there's just so many options. There are meetings that you can have with our faculty and a separate meeting with our department chair, Mary Leonard, who's also a pediatric nephrologist, and she knows everybody. So when you start fleshing out sort of your ideas or areas of interest, uh, we know people all over the place. There's a huge adult nephrology program, so we've had people working in hypertension labs, working in a cell biology lab, working trying to do figuring out what are uremic toxins with an adult dialysis doctor in a basic lab. But also throughout campus, there's engineers, there's physicists, there's mathematicians, there's an entire bioX for people who are doing molecular biology who want to do projects with medical school people. So there's lots of multidisciplinary options. There's a whole team that does global health, and there's a real developing subgroup of advocacy. So once you find your passion project, whether you know before you come in or whether you have no clue what kind of research you want to do as you're starting your first day of fellowship, we'll help you out and help you figure that out. Diversity. So obviously this is a very important topic, and Stanford is doing a ton to be as diverse as possible. The medical school recognizes that for people to be comfortable, they need to feel that they're accepted in a nurturing environment, and they need to see that there are other people like themselves, however they perceive that to be. So in our Department of Pediatrics, we are quite diverse. We have an equal number of males and females. We have people from Thailand, from China, from India, from people who are African American. I'm Canadian, if that counts. People from Thailand. We have the old and the young. So I think that's important. Many of the fellows over the years have had children while they were fellows, and we are welcoming of that. We have rearranged things to give people the best opportunity, and we think we're quite child friendly, and that's something to really talk about, because some of the fellows during your interviews have had pregnancies during their fellowship, and they can tell you what that was like and how we facilitated that. We also recognize that every human being has issues, and so there's a lot of wellness supports that are the topic of separate presentations. We have people who have dealt with chronic illness on our faculty. I'm not I'm not spilling any confidences when I explain that one of our faculty members lived through dialysis and transplant while he was a fellow. And when we ranked him really highly and matched him to our program, we knew that it was likely he would need dialysis while he was a fellow. And we felt that he was such a positive role model, we would make it work. And he now has had a great transplant and is doing great. But that's just one example. So our program, I think, is a place where we really like each other, where we really respect each other, where we have each other's backs. Oh, last week, on the weekend, we did a combined liver kidney transplant program, liver kidney transplant patient. And this patient had been in hospital for a couple of months, was close to death, and we were able to get him a successful liver and kidney transplant. Because of his kidney failure, and because there was expected to be massive blood transfusion and major electrolyte problems, we did CRRT for the entire case in the OR. And when we do CRRT, that means an attending or a fellow are actually in the OR the entire time. Because every 15 minutes we're getting labs back and we're adjusting the dialysis bags, we're adjusting the flows, we're adjusting the ultrafiltration with anesthesia to maximize the physiology to make it as normal as possible when there's huge fluid shifts that are happening during the liver transplant. And our anesthesiologists really believe that many of the patients who are so sick that would have died are survived because of our presence in the OR. So when this happened on a Saturday, the attending sent an email saying, hey, I'm going to need some help because I got around and I'm going to be in the OR. And within a short period of time, there were a bunch of attendings that emailed back, oh, I can do this period of time, I can do this period of time. This was a Saturday, and people jumped in to help. And the fellows also, said, look, I can give the fellow a break. I can come in for a few hours to cover. And this is routine. When there's an issue or a problem, it's not like you have to fight to find someone to cover. People are volunteering, and because we have each other's back. And we really try to be a place where everybody gets along and is supportive of each other. I'm happy I'm here. And if you apply and match, I think you will be too. So that's it. Not quite an hour. Normally, when I'm doing this with the fellows, there's questions. Can't have any questions right now, but write down your questions. And so when you're having your interviews, ask penetrating questions, ask probing questions. The reality is there's way more spots for fellowship in the USA than there are applicants. And so you should think of yourself as being courted by these fellowship programs because they really want you. And you've got more opportunities than you think. And so ask probing questions. What about this? What about that? And then when you're looking at different fellowship programs, you should think about how you learn best. And so like in our program, we have 9 fellows, 3 in a year. So it's a group. And there's lots of group interactions. And, the fellows like each other. Oftentimes they party together, socialize together. Sometimes we think too much, but they get along. And so there's a friendly rivalries and competitions as well. So is that the way you learn best, or are you more like a loner? Because the fellowship size will determine that. Like if you're someone who really learns well in a group and you go to a place where there's only like 1 or 2 fellows, you got to take that into account. In our program, the fellows are assigned to specific things. So like, they're on inpatient service or the outpatient service or whatever. So in your research years, you can be flexible. Like if you want to go and watch that transplant, great. If you're thinking that you want to be a medical director of a kidney transplant program, you have to have documented observation of deceased organ procurement. So you can do that. You've got lots of flexibility. We have an HLA course for people that are really interested in transplantation, and it's a short week course, which is for people who are organ transplant fellows, like transplant surgery fellows, or liver transplant fellows, or pediatric nephrology fellows, or heart failure fellows, or something like that. So there are these opportunities in a big place. On the other hand, in a small place, you know, where they don't have fellows all the time in the inpatient service. If you might have a time when the inpatient service is quiet, and so you might do something else. Or the inpatient service might be busy, and so you might spend time in the inpatient service then. So you don't have that flexibility in our program because you're assigned to the inpatient service, and it's always busy. It's not like you're ever going to not have enough to do, that's for sure. One of the other things about our fellowship program is the case mix. So I think of it as two models, and one model is where you have a set sort of closed referral area, and I'll use Emory as an example. So Emory has the state of Georgia, right? So any general nephrology anywhere in the state, hypertension, kidney stones, lupus, comes to them. And from that population comes their dialysis population and comes their transplant population. So they get a reflection of a population. That's totally not like our program here. Our general nephrology population comes from the Bay Area. And so we have a huge hospital and lots of referring practices. And so we get those referrals. But in addition, there's separate pediatric nephrologists and nephrology groups in the East Bay and Kaiser, at UCSF in the north, at the Santa Clara Valley Hospital. And then in Central California, there's Valley Children's. So they also do general nephrology. So, but from those, many of those don't do dialysis. So like Kaiser doesn't do their own dialysis. Santa Clara Valley doesn't do dialysis. And Children's of Fresno does peritoneal dialysis and stable older hemos, but not little kids. And so we get referrals from those centers. So if you think of concentric circles, this is where we get our general nephrology patients from. We get our dialysis patients from a bigger concentric circle. And then our transplant program gets patients from our dialysis population, but even bigger concentric circle because we do the kidney transplants for the state of Hawaii because of our relationship with the Hawaiian docs at Kapiolani. We do almost all the kidney transplants for the state of Nevada through our relationships with the people in Las Vegas and in Reno. We do kids under 40 kilos for the state of New Mexico. But in addition, because of our outstanding outcomes and because of our willingness to take a chance and try new things, we get desensitized disease patients. We get patients who don't have an IVC or have other surgical problems from all over the country. As I look on our waiting list and our desensitization list, we have patients that we're following from as far away as Michigan and from Portland and throughout the central states. And so our transplant population comes from even bigger. Our acute kidney injury population, because we have such a big liver transplant and heart surgery program, we do a ton of AKI. So at this program, you're going to see the breadth of all of pediatric nephrology, but you're going to see a lot of end stage. So you're going to see all the complications. And when you leave this program, you're going to feel totally comfortable with dialysis and transplant and AKI because we just see so much of that. You're going to see a ton of general nephrology. If you want to become a hypertension specialist, we can certainly make that happen. But as well, you'll be really well trained in those other areas. So where fellowship programs get their patients is something to think about when you're looking at different fellowship programs. So this is a fun time in your life, and it's also scary and stressful. And don't hesitate, after your interview day, if you have questions, don't hesitate to email or talk to our fellows. Our coordinator, Kim Sams, is a fount of information. And if there's anything we can do to help you discern what's right for you, let us know. Okay, thank you very much. And I hope this has been helpful. Bye for now.